Welcome, future pharmacists. Let's explore iron deficiency anemia, one of the most common causes of anemia worldwide and a frequent scenario in clinical practice. Iron deficiency anemia occurs when the body cannot produce sufficient red blood cells due to depleted iron stores. As pharmacists, understanding its management is essential for optimizing treatment and improving patient outcomes. There are several underlying causes of iron deficiency. Common examples include chronic blood loss, often from gastrointestinal sources or heavy menstrual bleeding, malabsorption syndromes such as celiac disease or inflammatory bowel disease, and increased physiological demands, especially during pregnancy. Once iron deficiency is confirmed, iron replacement therapy should begin immediately. While investigations to determine the cause continue, pharmacists must ensure that treatment is not delayed, as prolonged deficiency can worsen clinical outcomes. Oral iron remains the first-line therapy. Several iron salts are available, including ferrous sulfate, ferrous fumarate, ferrous gluconate, ferric maltol, and sodium ferritatite. While all are effective, they differ in the amount of elemental iron delivered per dose. For example, 210 mg of ferrous fumarate provides approximately 69 mg of elemental iron, 200 mg of ferrous sulfate delivers 65 mg, while 300 mg of ferrous gluconate contains only 35 mg. The choice of formulation depends on required dosing, patient tolerance, availability, and cost. Traditionally, iron was prescribed 2 to 3 times daily, but current evidence supports once-daily dosing. This approach maintains efficacy, reduces side effects, and improves adherence, which pharmacists should reinforce during counseling. Monitoring is critical, and pharmacists should review hemoglobin levels within 4 weeks and ensure treatment continues for at least 3 months after normalization to replenish iron stores fully. Iron therapy can cause side effects, and one of the most common is constipation. Nausea, epigastric discomfort, and dark stools may also occur. As pharmacists, you should recommend strategies to minimize these, such as taking tablets with food if tolerated, considering a switch to a different salt formulation if side effects persist, and advising the use of ascorbic acid or vitamin C to enhance iron absorption when clinically appropriate. However, pharmacists must also evaluate potential drug interactions, particularly with antacids, calcium supplements, tetracyclines, and proton pump inhibitors, which may impair absorption. In pregnancy, combination products containing iron and folic acid are commonly prescribed for prophylaxis. However, these low-dose folic acid formulations are not sufficient for treating megaloblastic anemia. Modified-release iron preparations should also be avoided, as they release iron beyond the duodenum, reducing absorption and offering no therapeutic benefit. For patients who cannot tolerate oral formulations, have malabsorption, or require rapid replacement, such as those on hemodialysis, parenteral iron can be considered. Options include iron dextran, iron sucrose, ferric carboxymaltose, and ferric derisomaltose. Pharmacists play a key role in dosing adjustments, monitoring ferritin levels, and recognizing infusion-related adverse events. Iron deficiency anemia is highly treatable, and pharmacists are central to its management by selecting the most suitable formulation, counseling on dosing and adherence, managing adverse effects and interactions, and ensuring appropriate monitoring to confirm treatment success. By providing evidence-based recommendations and optimizing therapy, pharmacists directly improve patient care and outcomes. If you found this valuable, like, share, and subscribe for more insights on clinical pharmacy and evidence-based therapy.